Hello. Thank you for joining me today for this infectious diseases workshop on pneumonia, urinary tract infection, and Clostridioides difficile infection. I'm Nitin Gopalsamy. I'm one of the ID docs at Mount Sinai, and it's my pleasure to be giving you this talk today. I don't have any financial disclosures. My main content disclosure is that we'll try to focus on community-acquired infections and the outpatient management for the elderly, but we will include information across the spectrum of each of these infections and incorporate guideline-based recommendations. For my learning objectives, I'd like for you to be able to recognize the risk factors, particularly among the elderly, for pneumonia, UTI, and C. diff infection, to be able to distinguish the clinical manifestations of pneumonia, UTI, and C. diff infection, focusing on symptomatology and disease severity, and to have a framework to select appropriate antimicrobial therapies for these infections, considering the severity of presentation and current recommendations for antibiotic stewardship and optimal duration of therapy. We'll start off with pneumonia and get started with a question. We have an 82-year-old man with poor oral hygiene who comes in with fever, productive cough, and new infiltrates in the right lower lobe. He's a nursing home resident with a history of recurrent aspiration events. Which of the following organisms is most likely responsible for this presentation? Aerobic gram-negative bacilli, such as E. coli or Klebsiella pneumoniae, anaerobic oral flora, such as Bacteroides species or Fusobacterium species, Mycoplasma pneumoniae, Legionella pneumophila, or Pseudomonas aeruginosa. Please feel free to pause at this point and think further about this question. I'll come back to the answer at a future slide. So let's start off with some definitions. So for pneumonia, it's broadly categorized usually as community-acquired pneumonia, or CAP, and nosocomial pneumonia. Within nosocomial, we then categorize either as hospital-acquired pneumonia, or HAP, which occurs at least 48 hours after admission, or ventilator-associated pneumonia, or VAP, which occurs at least 48 hours after intubation. Please note that healthcare-associated pneumonia, or HCAP, has been retired as a term. So community-acquired pneumonia now includes patients who formerly may have been under that designation, namely those who acquired pneumonia after recent hospitalization or while they're residing in a nursing home. In thinking about the risk factors for pneumonia, the most prominent one is particularly relevant to this audience, and that's age of at least 65 years. Other risk factors include chronic comorbidities, especially chronic obstructive pulmonary disease, or COPD, impaired airway protection, which increases the risk of aspiration, smoking, alcohol, and opioid use, poor oral health and nutrition, environmental exposures, particularly to metals, dusts, or fumes, and immunosuppressive therapies. I hope you can note that age is an independent risk factor, but also appreciate that all of these other risk factors are probably also disproportionately present among our elderly population. In looking at the microbiology, the first thing to note with pneumonia is that a definitive microorganism is often not identified. In the etiology of pneumonia in the community, or EPIC study, of nearly 2,500 patients hospitalized with CAP, only 38% had pathogens identified. When we did identify a pathogen, in most common case, it most commonly involves viruses. Historically, that was rhinovirus and influenza A or B, but now it also commonly involves SARS-CoV-2, the virus that causes COVID. Keep in mind that among the elderly, there's a higher risk of respiratory syncytial virus, or RSV. Among bacteria, Streptococcus pneumoniae is the most common cause of community-acquired pneumonia, but keep in mind that polymicrobial and gram-negative infections are more common among the elderly because of a greater risk of aspiration. Bacterial infections are also more common than viral among those who have severe CAP, especially those who are in an ICU setting. In further trying to elucidate the potential pathogen involved in a pneumonia, it's important to think about the risk factors or the specific circumstances of their presentation. For example, with aspiration pneumonia, the most common pathogens are Enterobacteriaceae, such as E. coli or Klebsiella pneumonia, or Staph aureus. These bugs have actually now superseded anaerobes as the primary driver of aspiration. While you could also worry about poor dental hygiene and alcohol use disorder associated with anaerobic infections, you really need to worry about covering or dedicating coverage for anaerobes if there's the presence of a lung abscess, as well as Legionella infection. And with viruses, you want to keep in mind of the risk of secondary bacterial pneumonia, particularly from Streptococcus pneumoniae, Staphylococcus aureus, and Haemophilus influenza. With COPD, structural lung disease, and glucocorticoid therapy, that's when you should have a higher index of suspicion for Pseudomonas aeruginosa, as well as some of these other bugs listed here for your reference. Hospitalization within the past 90 days with receipt of parenteral antibiotics is when you should most commonly think about MRSA and Pseudomonas infection. Frequent parenteral antibiotic exposure can also increase the likelihood of nosocomial pathogens such as Stenotrophomonas and Acinetobacter species. I think you're less likely to be tested on these last two bugs, but they're here for your awareness in your clinical practice. So to go back to this question, the stem is describing aspiration pneumonia. So the most likely organisms of the ones listed here would be aerobic gram-negative bacilli. Note that Staph aureus would also be a correct answer if it was given as one of the options. Now, digging deeper into the presentation of CAP. Just as with the microbiology, there's a level of ambiguity. There's no single sign or symptom, nor combination of signs or symptoms that reliably diagnose pneumonia. The classic symptoms are fever, new or increased cough, change or increase in sputum production, and new or increased dyspnea. And the signs to look for on exam and on vitals are oscillatory findings of consolidation, such as rales, crackles, sigophony, as well as hypoxia and tachypnea, defined as a respiratory rate of at least 20 breaths per minute. It's important to note, though, that these findings, the signs are more subtle among the elderly. Fever in particular is less common, and sometimes altered mental status may be the sole presenting symptom. But please keep in mind that altered mental status is not specific for pneumonia. It can be seen with many other infectious and non-infectious etiologies. So you should really contextualize it alongside other signs of pneumonia or imaging findings. Briefly on HAP and VAP, just as with CAP, this presentation can be nonspecific. The general approach is that you're looking for a new lung infiltrate and some evidence that the infiltrate's of infectious etiology. Either there's purulent sputum or secretions, fever, leukocytosis, or an increased oxygen requirement. So to follow along with the same patient, you find out on further history that he's had no recent hospitalizations and no history of respiratory isolation of MRSA or Pseudomonas. His vital signs are notable for a temperature of 38.4, blood pressure of 100/64, heart rate of 104 beats per minute, and a respiratory rate of 32 breaths per minute. On exam, he's only oriented to self. At baseline, he's usually fully oriented, and he has bilateral crackles. The labs are notable for a white blood cell count of 14,500, a BUN of 41, and a creatinine of 1.8. So the most appropriate treatment is oral therapy with amoxicillin, clavulanate, and doxycycline, combination therapy with parenteral ceftriaxone and oral azithromycin, oral therapy with levofloxacin, parenteral therapy with vancomycin and ceftriaxone, or parenteral therapy with cefepime. So in thinking about how to approach the treatment, you first want to determine the severity of their presentation. The guidelines describe specific criteria to determine if someone has severe CAP. And it's primarily at least 3 of the following minor criteria, which I'll leave here for your reference to review at a later time, or 1 major criteria. The major criteria is essentially critical illness, either septic shock with the need for vasopressors or respiratory failure requiring mechanical ventilation. So with that in mind, there are also certain tools that you can use per the guidelines to help triage CAP to determine whether or not you can treat them on the inpatient setting or if you could do this as outpatient. The 2 main tools listed in the guidelines are the Pneumonia Severity Index, or PSI, and CURB-65, with the former being preferred over the latter. The PSI generally involves this framework. So first of all, you start off, I hope you can again appreciate the prominence of age as a risk factor. So if they're over 50, or they have some of these comorbid conditions, or have concerning exam and vital signs, you would then move on to using the scoring algorithm, where points are assigned based on their demographics, whether they reside in a nursing home, coexisting illnesses, physical exam findings, and lab and imaging findings. This is quite an extensive list, and it has been well validated, but I hope you can also appreciate that this is quite labor and data intensive. So with that in mind, the authors do acknowledge that while CURB-65 is deemed to be less effective than PSI, it is conditionally recommended because of its simplicity of use. So CURB-65 is essentially an acronym. The C stands for confusion, U for urea with a BUN of over 19, a respiratory rate of 30 breaths per minute, and the B for blood pressure, systolic less than 90 or diastolic less than or equal to 60. And the 65 refers to them at least being of 65 years of age. And based off these 5 variables, if they have a score of less than 2, you can treat them as an outpatient. If they have a score of 2, think about a short inpatient stay. Or if you have a setup such as hospital at home, you could consider a supervised outpatient. And if they score at least 3 or higher, they would be considered to have a more severe infection, and you should treat them inpatient, possibly in the ICU. In some of the diagnostics for CAP, and this is beyond chest X-ray, one of the first things you should think about is SARS-CoV-2 and influenza testing. The literature suggests that you should obtain it if the virus is common in the community or there's a potential exposure. I would argue that's pretty much always going to be the case. So this is one of the tests you're going to order on most patients. Sputum and blood cultures, however, should not be obtained routinely, particularly in the outpatient setting. You should really only think about obtaining them if you're classifying the disease as severe CAP or if you're treating inpatient empirically for MRSA or Pseudomonas. The MRSA nasal swab should also be utilized in severe CAP and if there are risk factors for MRSA. Legionella and pneumococcal urinary antigen testing should not be obtained routinely. You could consider it if they're available when treating severe CAP. And lastly, lung ultrasound has now gained greater favor. And in the current tentative Thoracic Society guidelines, they're noted to be an acceptable alternative to chest X-ray in medical centers where you have appropriate clinical expertise and possibly not ready access to radiology. There's some general principles to first consider with treatment. First of all, it's controversial whether or not you should still give antibiotics to someone if they test positive for a respiratory virus. The guidelines vary on this. I don't think you would be tested on this. The one caveat is that it's generally agreed that for patients with influenza, you should give them empiric antibiotics because of the greater risk of secondary bacterial pneumonia. Again, a reminder that HCAP is no longer its own category, so your determination of whether or not they need MRSA or Pseudomonas coverage should be based on the local epidemiology and of one of the following risk factors: either prior isolation of MRSA or Pseudomonas, or they've been hospitalized and received parenteral antibiotics in the last 90 days. This chart is here primarily for your reference because we'll refer to drug classes in the subsequent slides when building a framework for treatment of pneumonia. The medications highlighted in pink are those that are deemed to be beta-lactams with anti-pseudomonal coverage. So first, how do you treat outpatient CAP? If they don't have any comorbidities or risk factors for MRSA or Pseudomonas, you primarily will use monotherapy with either amoxicillin or doxycycline. You could consider using a macrolide, but you would need to know your local resistance profile. If they do have comorbidities, then you would likely employ a combination approach with a beta-lactam, either amoxicillin clavulanate or cephalosporin, in combination with a macrolide or doxycycline, with the latter providing you a Legionella and other quote-unquote atypical coverage. You could also consider using a respiratory fluoroquinolone as monotherapy, though I will say in ID, we generally try to spare the quinolone if possible, primarily because it's our lone oral anti-pseudomonal, and in the elderly population, it has a very concerning side effect profile. If they have non-severe CAP, but you're treating them inpatient, the standard approach would be to use a beta-lactam plus a macrolide. You could, again, consider a respiratory fluoroquinolone, though we try to shy away from it if possible. If they have prior respiratory isolation of MRSA or of Pseudomonas, you could add dedicated coverage for either of those bugs, but you want to obtain culture and nasal PCR so that you can de-escalate if neither is present, or to confirm to yourself that you do need to continue dedicated treatment. If they were recently hospitalized, got IV antibiotics, and have risk factors for MRSA or Pseudomonas, if they have non-severe CAP, you don't need to initiate dedicated coverage. Only do so if you have culture data or a positive nasal PCR. In severe CAP, the standard approach is to still start with a beta-lactam or macrolide. If you choose to use a respiratory fluoroquinolone, you should add a beta-lactam to it. If they have prior respiratory isolation of MRSA or Pseudomonas, again, think about the dedicated coverage. And in this case, if they've been recently hospitalized and received IV antibiotics and have risk factors for MRSA or Pseudomonas, you can also go ahead and empirically add the dedicated coverage. But you should get cultures, get the nasal PCR so that you can see if you can de-escalate your coverage or confirm that you need to continue one or both of the agents. Some additional considerations with CAP. So procalcitonin is a tool that's gained favor over the past few years. Keep in mind, you shouldn't use it routinely to determine initiation of antibiotics. You should still treat empirically based on their clinical presentation. It's primarily a tool to use potentially for de-escalation or discontinuation of antibiotics. So if you use a procal in combination with respiratory viral testing, beyond just a SARS-CoV-2 or influenza testing, maybe a multiplex PCR, you can then use that even in severe CAP to help determine whether you truly need antibiotics or if you could discontinue antibiotics. For example, they have severe CAP, but they test positive for rhinovirus and their procalcitonin is low. Potentially, you could defer antibiotics. Though this is controversial, so I don't think you would necessarily be tested on the procalcitonin. With corticosteroids, there's now greater data to support its use, but you should really only consider it with severe CAP. The caveat being if they have influenza, in which case corticosteroids are not recommended. Follow-up chest imaging is also generally not recommended. The duration of therapy depends on the severity of infection. If it's outpatient CAP, the guidelines suggest a minimum of 5 days. The more recent data suggests even 3 days may suffice. And in not severe inpatient treatment, again, 3 to 5 days may be enough. If they have MRSA or Pseudomonas, you want to treat for at least 7 days. With severe inpatient pneumonia, again, generally you're going to treat for at least 7 days. But keep in mind that these patients were not in part of trials where they looked at duration of therapy for CAP. Just briefly on HAP and VAP with diagnosis and treatment. So with diagnosis, non-invasive sampling, particularly with endotracheal sampling, is recommended over bronchoscopy when obtaining cultures. And the procalcitonin is not validated in this setting. The treatment should be guided by culture data instead of exclusively being empiric. When you are doing an empiric regimen, you should base it on local antibiotic resistance data. And you can cover MRSA and Pseudomonas while you're waiting for the nasal PCR and culture. And the duration is generally around 7 days. So to go back to the question, the STEM gives you several variables to suggest that this is severe CAP. The patient's age, his respiratory rate over 32, the fact that he's only oriented to self, and that his BUN is elevated. With that in mind, the correct answer would be to pursue a therapy with beta-lactam and macrolide. It would be premature to use oral therapy in this case, given the severity of the illness. And you don't need to do parenteral therapy with MRSA or Pseudomonas coverage because the patient does not have any history of MRSA or Pseudomonas isolation. So he's improved with therapy and he's completed a 5-day course of antibiotics. He's since recovered, has come to your clinic for a follow-up visit 3 months later. He had previously deferred pneumococcal vaccination, but is now interested. So which vaccine series should he receive? The 21-valent pneumococcal conjugate, or PCV21, the 13-valent conjugate, or PCV13, the pneumococcal polysaccharide vaccine, PPSV23, or the 13-valent plus the pneumococcal polysaccharide a year later. So the current vaccine recommendations for respiratory infections are as follows. For influenza, as you may know, it's recommended for all adults, but keep in mind that the higher dose or adjuvanted vaccine is recommended for adults who are at least 65 years old. With RSV, the guidelines have changed recently. Per the CDC, it's recommended for all adults over 75, though some would say over 60. And for adults between 50 and 75, it's recommended for those at increased risk for severe disease, namely those with certain comorbidities or those who reside in a nursing home. I think it would be harder to develop a board question on RSV vaccination. With pneumococcus, note that since October of last year, there's now a lower age cutoff. It's now recommended for all adults over 50, not just over 65. And the higher valent conjugate vaccines, namely PCV20 and PCV21, are now preferred because they account for the serotypes of pneumococcus that are most often implicated in adult infection. So this is the current framework that's recommended by the CDC. As you can see, things are really simplified at this point. For most patients, you're going to use PCV 20 or 21. The one time you'd consider the polysaccharide vaccine is if they previously received PCV 15. This bottom part is primarily for your clinical practice rather than for the boards. Keep in mind, if they previously completed what was thought to be a complete series with 13 and 23, you could still think about giving them PCV 20 5 years after their last pneumococcal vaccine, but though this would be based on shared decision-making with the patient. So to go back to this question, the best answer of the ones available would be PCV 21. We'll now move on to urinary tract infection. So we'll start off, we have a 62-year-old woman, postmenopausal, who comes in with 1 month of dysuria, urinary urgency, and increased frequency. She reports no fever or flank pain. Her urinalysis positive for pyuria and negative for bacteriuria. On examination, vulvovaginal atrophy is noted. So what's the most appropriate treatment? Nitrofurantoin, ciprofloxacin, intravaginal estrogen, ceftriaxone, or trimethoprim sulfamethoxazole. So some definitions. So UTI is broadly categorized as either uncomplicated or complicated. Earlier this year, the Infectious Disease Society of America, or IDSA, updated the recommendations, and the framework is now, I would argue, quite simplified. So an uncomplicated UTI essentially refers to any infection that's confined to the bladder, so a cystitis, and the patient doesn't have a fever. And this is the case in women and men. So gone are the days of a UTI in a man automatically being a complicated UTI. If they're afebrile and they have a cystitis, it's uncomplicated. A complicated UTI is any infection beyond the bladder in women or men. So this includes pyelonephritis, a UTI in which they have fevers or are bacteremic, catheter-associated UTI, or prostatitis in men. And thinking about the presentation, so again, uncomplicated is essentially afebrile cystitis. So that refers to dysuria, urinary frequency, urinary urgency, suprapubic pain, and hematuria. Complicated UTI can be any of the above, as well as fever, chills. With pyelonephritis, you may have focal signs or symptoms such as flank pain, costovertebral angle tenderness, and nausea or vomiting. Please note that altered mental status in and of itself does not equal UTI. As noted in the pneumonia section, you could be altered from a community-acquired pneumonia, other infections, or other non-infectious etiologies. So really, you should contextualize the altered mental status alongside focal GU exam findings or imaging findings. So with that in mind, one of the most common things I certainly run into in clinical practice, but something that could also come up in the boards, are presentations that are often mistaken for UTI. So one is asymptomatic bacteriuria. This refers to bacteria that's found in the urine, but the patient does not have any UTI symptoms. This does not require antimicrobial treatment. It's particularly prevalent in the elderly population. Some studies cite at least 20% of women over 80 having asymptomatic bacteriuria, and up to 15% of men over 75 also having the same issue. Some other risk factors include diabetes, the presence of an indwelling catheter, and neurogenic bladder, such as in people with spinal cord injury. So really, the only time to consider treatment would be in pregnancy, prior to a urologic procedure, and early in the period post-renal transplant. I doubt you would be tested on that latter point. With candiduria, it's rarely pathogenic. Candida in the urine usually reflects colonization. So again, we treat in very few scenarios, primarily very low birth weight infants, neutropenic patients, and prior to urologic procedure. Note that pyuria, defined as at least 10 leukocytes per microliter, in and of itself is not really a marker for UTI. It's just one more data point to contextualize with the rest of the presentation. Some of the most common symptoms that are mistaken for UTI are chronic dysuria and urinary incontinence. The key word here is chronic, and this is a particularly issue among the elderly. So you want to look out for new urinary urgency or incontinence, gross hematuria, or suprapubic pain, as they are more specific symptoms for a UTI. Among peri and postmenopausal women, you want to be especially mindful of genitourinary syndrome of menopause, which was previously referred to as vaginal atrophy or atrophic vaginitis, as it's a common mimic for UTI. Urethral and vaginal discharge are more specific for urethritis and vaginitis, which are more commonly implicated in sexually transmitted infections. And among women, you should also think about Candida vaginitis and bacterial vaginosis. So to go back to this question, there are a couple of important points highlighted here from the STEM. You have a postmenopausal woman. The symptoms have been going on for a month, and you have vulvovaginal atrophy on exam. So this is most consistent with genitourinary syndrome of menopause. And the treatment would be intravaginal estrogen rather than intramicrobial therapy. So our next question now involves a 78-year-old woman who comes in with acute onset dysuria, urinary frequency, and suprapubic discomfort. She's afebrile, has no flank pain, and denies vaginal discharge. Her past medical history is notable for hypertension and osteoarthritis. Which of the following is the most appropriate management? Would it be empirical antimicrobial therapy with nitrofurantoin for 5 days, empiric antibiotics with ciprofloxacin for 14 days, wait for the urine analysis and urine culture before initiating treatment, or empiric antibiotic therapy with amoxicillin clavulanate for 10 days? So in thinking about the best treatment, we want to, again, think about the microbiology. So the most common pathogen isolated is E. coli, particularly in cases of cystitis. The additional bugs to think about are other species of Enterobacteriaceae, such as Klebsiella pneumoniae and Proteus mirabilis, as well as Staphylococcus saprophyticus. Healthcare exposure and the presence of an indwelling catheter are some of the factors to think about if you're worried about Pseudomonas aeruginosa or Staphylococcus aureus. Keep in mind, Staph aureus in the urine is often a complication of staph in the blood translocating to the GU tract. So you should have a low threshold to suspect a primary bacteremia and get blood cultures in these patients. You should really think about multi-drug resistant or MDR gram-negative infections if they have some of these factors within the past 3 months, including the presence of a urinary isolate with an MDR gram-negative or a fluoroquinolone-resistant Pseudomonas, inpatient stay at a healthcare facility, and this includes nursing home and long-term acute care or LTAC facility, the use of a fluoroquinolone, trimethoprim sulfa, or a broad-spectrum beta-lactam, or travel to parts of the world with high rates of MDR organisms. Again, this table is here for your reference of the various drug classes that we'll refer to in future slides and building a framework for UTI treatment. So for uncomplicated UTI, the first thing you want to keep in mind is that you can treat these patients empirically, especially in case of women where we have a lot of data to support empiric UTI treatment. And the antibiotics we use, there are 4 first-line agents, but really the top 3 are what are most commonly used in the United States. So this would be nitrofurantoin, trimethoprim sulfa, and fosfomycin. Note that the durations vary based on the agent, and the durations are generally shorter for women, though more studies need to be done in men to see if we could get away with shorter durations. If none of these agents are an option, that's when you would think about a beta-lactam or a fluoroquinolone. And if you have concern for an MDR organism based on some of the factors we discussed in the previous slide, or none of the above drugs are ideal due to possibly a side effect profile or prior culture data, that's when you would obtain a culture. You could still empirically try one of these agents if you want, especially if you're going to try to treat them as an outpatient. Maybe pick the best, the least bad of these options, or you may just have to proceed to parenteral therapy. And the framework for IV therapy is generally the same framework you'd use when approaching complicated UTI treatment. So the first question is, do they have sepsis? If they do, you want to use a stronger parenteral treatment. What do we mean by stronger? So 3rd or 4th generation cephalosporin, piperacillin tazobactam, a carbapenem, or possibly a fluoroquinolone. They don't have sepsis, but you want to use IV. Either they can't tolerate PO or the severity of their presentation. Otherwise, you could still use a 3rd or 4th generation cephalosporin, piperacillin tazobactam, or fluoroquinolone. Again, keep in mind, we try to spare the fluoroquinolone if possible. If they're able to do PO, and even if they have a complicated UTI, you could try to use fluoroquinolone at this point or trimethoprim sulfa. So keeping in mind with PO, say you start off with IV, when can you think about transitioning to PO? And then what's the overall duration of therapy? It's quite intuitive when you can use oral. It basically comes down to if they've gotten better, they're able to take PO, and you have a PO option. The duration of therapy is generally 5 to 7 days. If you're using a fluoroquinolone to complete the course, you can try to limit that exposure and do a course as short as 5 days. If they have an associated bacteremia, in that sort of scenario, you would favor 7 days. You can think about a longer course in the range of 10 to 14 days. If they've been slow to improve, maybe they had a need for source control, possibly a kidney stone or a perinephric abscess that required drainage, or if there's acute bacterial prostatitis. So there's really limited data for that recommendation. So to go back to this question, the presentation is essentially describing an uncomplicated UTI or afebrile cystitis. So the most appropriate option out of the ones given would be nitrofurantoin for 5 days. When I think about prevention with UTIs, I really think about how to prevent recurrent uncomplicated UTIs among women. This is defined as at least 2 infections over the past 6 months, or at least 3 infections over the past year. You should always keep in mind that you may need to pursue imaging or urologic evaluation. If there are other features suggesting structural or functional abnormalities of the GU tract, maybe they have an anatomic defect that could be addressed by urology, or they have an issue with aging and could benefit from urogyne rehab for incontinence. Beyond that, though, there's a 4-step approach you could take to prevention for recurrent uncomplicated UTIs. You start off with behavioral changes that could be increasing fluid intake, stopping spermicide use, postcoital voiding, or improving hygiene. If that doesn't help, you could think about, especially in postmenopausal women, treating vaginal dryness with intravaginal estrogen. You could certainly do these steps in combination. If they're still having recurrent infections, that's when we may turn to antibiotic-sparing medications such as methenamine, which is an antiseptic, or cranberry products. None of these avenues help. That's when you would consider antimicrobial prophylaxis. Specifically, you could take a postcoital approach with nitrofurantoin or trimethoprim sulfa, or a continuous approach with either of these agents, a beta-lactam or phosphomycin. Now we'll finish off discussing Clostridioides difficile or C. diff infection. So we have a 79-year-old woman residing in a skilled nursing facility who develops new onset watery diarrhea and abdominal discomfort after completing a 10-day course of oral cefuroxime for pneumonia. Note that that duration is longer than what would be recommended. She's hemodynamically stable, afebrile, and her lab studies reveal a positive stool test for C. diff toxin. She has no prior history of C. diff infection. So according to the most recent guidelines, which of the following is the most appropriate initial therapy? Oral metronidazole, oral vancomycin, intravenous vancomycin, oral fidaxomicin, or oral rifaximin. So a brief introduction. C. diff is a spore-forming, toxin-producing, gram-positive anaerobe. There are standardized case definitions that we use for surveillance of CDI, broadly categorizing as healthcare facility onset, community onset, and healthcare facility associated or community associated CDI. The primary risk factor for C. diff infection, of course, is antibiotic use within the past 30 days. But the next prominent one, again relevant to this population, to this audience, is age of at least 60 to 65 years. Other risk factors include hospitalization within the previous 30 days, severe comorbid illness, and the use of gastric acid suppressive agents, particularly proton pump inhibitors. With recurrent infections, the primary risk factor is age, over 65, as well as severe underlying medical illness, especially inflammatory bowel disease and malignancy, the need for ongoing systemic antibiotics, especially the concomitant use of systemic therapy while on C. diff treatment, and a serum creatinine of at least 1.2 at the time of C. diff diagnosis. The main presentation is watery diarrhea, which is defined as at least 3 loose stools over the past 24 hours. You can also have fever, nausea, anorexia, and abdominal pain, and the stool can have mucus, but it's rarely bloody. Severe C. diff is defined as a white blood cell count of at least 15,000 cells, or a serum creatinine of at least 1.5. And fulminant infection is defined as hypotension or shock, or ileus, or megacolon. Keep in mind that you can get C. diff without diarrhea and just ileus. This generally portends a poor prognosis and often is a sign of possible fulminant infection. You can also have asymptomatic carriage of C. diff without symptoms. This occurs in up to 20% of people who are hospitalized. and half of long-term facility residents. So this is quite a common phenomenon. So please, please, please do not screen for C. diff in the absence of symptoms. The diagnosis of C. diff generally involves an algorithm. There are different ones in different labs, but it generally involves a two-tiered approach with a highly sensitive test followed by a highly specific test. These are the most commonly available tests for C. diff at this point. You have a nucleic acid amplification test, or a NAT, which is a PCR test targeting the gene for the toxin produced by C. diff. You also have a glutamate dehydrogenase test, which is targeting an antigen specific to C. diff. And then you have a toxin immunoassay, or EIA, targeting the target toxin produced by C. diff. The first two tests are the sensitive ones. The toxin EIA is the specific test. We generally believe that you need toxin production to have a clinically significant C. diff infection. So the algorithm could look something like this. Your lab either has a NAT or PCR test, or it utilizes the GDH antigen test. This is a highly sensitive test, so it's a good rule out test. So this is negative, you don't have C. diff. If it's positive, you move on to the specific test, namely the toxin EIA. If that's positive, you have a confirmed infection, go ahead and treat them for C. diff. If it's negative, that's when we would turn the result to be indeterminate. I'm not sure you'd be tested on this pattern, but something for you to be aware of in your clinical practice. This most likely reflects asymptomatic carriage. Keep in mind that PCRs can often identify dead or inactive genetic material from an organism. So you could just have asymptomatic carriage of C. diff. But the other small possibility is that the toxin was a false negative. So our general clinical approach is that you could think about treating these patients if they're severely ill or you don't have any other clear explanation for their diarrhea. So how do you treat them? Well, of course, the first step is try to discontinue systemic antibiotics. If they have a concomitant systemic infection, you may need to continue therapy, but try to limit the course if possible. The treatment itself, so if it's their first episode and it's non-fulminant, the preferred option now is fidaxomicin for 10 days. Again, the guideline authors note that availability can be an issue, but if all other things are equal, this is now the first line option. If it's not available, you can use vancomycin for 10 days. In fulminant disease, you would use vancomycin orally or through a NG tube in combination with parenteral metronidazole. If they have ileus, you could think about rectal vancomycin, and the duration would be based on how their clinical course evolves. You should also think about early surgical consultation to determine the utility of a colectomy. With recurrent episodes, depends on the number of recurrence. So if it's their first recurrence, which would mean that it's their second episode, you would utilize prior treatment. It depends on what their prior treatment was. So if they previously got fidaxomicin, you would now try vancomycin, or vice versa. If they first episode got vanc, now try fidax. With their second recurrence, which would now be their third episode, now you would think about, if you haven't tried fidax before, you could try it again for 10 days, or probably use a more extended duration, or utilize vanc now with a taper. But this is really when you should think about fecal microbiota products or transplantation. If it's any subsequent recurrence, you could think about longer courses of fidax or vanc, or using rifaximin after vanc. But again, really, you should refer them for fecal microbiota products or transplantation. Some of you who may be familiar with the guidelines may be noticing the omission of bezlotuximab, which is a monoclonal antibody against C. diff. Unfortunately, it's no longer produced in the United States, so it's really no longer part of our framework for treatment. So in this, to go back to this question, the most appropriate initial therapy now per the guidelines is oral fidaxomicin rather than vancomycin. I'll finish off with a brief mention about prevention. Of course, the first line of prevention of C. diff is to minimize antibiotic use. You could also try to avoid gastric acid suppression, particularly with long-term PPI use. Secondary prevention, which would be with the use of oral vancomycin twice daily while they're on systemic antibiotics, followed by a tail after they finish systemic therapy, should really be considered for patients who are at high risk for recurrence. Again, the most notable risk factor is their age, but you could also think about it for people who are severely immunocompromised. There's no data to support the use of probiotics. And the last thing, of course, is a plug for infection control. This is really our main tool for C. diff prevention at this point. And the recommendation is for contact precautions. In some facilities, you may see this termed as special contact precaution. That's because you need to be doing hand washing with soap and water. This is more effective at killing the spores from C. diff than alcohol-based hand sanitizers. And this should be done before and after patient contact. Thank you for taking the time to listen to this workshop. And I'd be happy to get any feedback from you through the course directors about ways to improve this talk for potential future use.